good evening, and a warm welcome to all the delegates and faculty members to the virtual meeting on the PARP Inhibitors. Now, let us begin with our program, and for that, I would like to invite our chairman, Dr. Ashok Vaid sir, for welcome address. He is a chairman in the Department of Medical Oncology and Hematology at Medanta, the Med City, Gurugram. Over to you, sir.
Thank you so much. At the very outset, I thank everyone, all the speakers and the panelists for taking time out, and all those who have logged in, who are attending this program. We have very exciting 2 lectures followed by a panel discussion, and I'm sure through the proceedings, we would be learning a lot of new things about the PARP inhibitors. This is a group of agents which has brought in a new horizon to the treatment to many tumors, many solid tumors, notably breast cancer, ovarian, prostate, and now the indications are expanding not only as a single agent, but also in combination with VEGF inhibitors. And soon we will have some combinations with the immunotherapies as well. Also, my sincere thanks to Benish and BDR Pharma for sponsoring this program, for bringing the concept to us actually. And we then collaborated with them to bring this program to all of you. I hope it'll be a great learning experience. And I hand over the proceedings back for continuation of the lectures and the panel discussions. Friends, thanks once again, and we look forward to great interactions and another program on one of the very interesting subjects soon enough through Indian Oncology Foundation and MICE Ideas. I thank Rajesh and his team for collaborating month on month in bringing these programs live and alive to all of us. Thank you so much. Back to the moderation. Thank you.
Thank you so much, sir. Now, moving ahead, I would like to invite our first speaker, Dr. Nikhil Vaid. He is an associate consultant in the Department of Radiation Oncology, Artemis Hospital, Delhi, and he is going to speak on PARP inhibitors in prostate cancer. Over to you, sir.
Dr. Nikhil, are you there?
Sir, we are not able to hear you. Hello. Hello, sir, you are not audible.
Oh. Hello.
Yes, sir.
Now it's audible.
Yes, sir, you are audible now.
Yeah.
Sir, just put your slides in
This
slideshow mode.
slide.
Okay.
Sorry. Yeah.
Okay, sir.
This is a slide. In the first column, we can see the most common, which is a single stand break, and the repair was this is basic CN repair, which is the main repair target are the PARP and AP. In second column, we can see the most common cytotoxicity, that is a double strand break, and the repair pathway for this is the homologous recombination repair and the non-homologous and joining. And the repair targets are the ATR, ATM, and DNAP. The damaging agents for this double strand break is topo 1 and topo 2 inhibitors along with the nucleoside analog. The third one is the bulky adduct, which result from platinum and the ultraviolet rays. And the repair pathway for this is nucleotide oxygen repair and the translesion synthesis. And the repair targets are the ERCC1, XP protein, and polymerase. And in the last column, we can see that nucleotide mutation, substitution, deletion, and return. And the repair pathway for this is the mismatch repair. And the repair targets are the MLL, MLH, and MSH. And in this slide, this log survival curve was first published in the Nature in the 2005 by Brent et al., who stated that targeting the DNA repair defect in mutant cell can be as a therapeutic strategy. And clearly we can see in the log survival action concentration, there is a significant difference in the BRCA component mutated as compared to the BRCA non-mutated. So inhibitors mode of action, PARP helps cell, including the cancer cell, survive and grow by repairing the DNA damage in cells so that they can survive. In cancer cells, the patient will want to stop this here so that they can survive. Here the role of the pulp, which helps kill cancer cell by preventing the PARP from repairing the DNA. As PARP is also found in the healthy cells, so olaparib may affect them. The PARP inhibitors mechanism of action. Whenever there is a damage to the cell, PARP along with the BRCA1 or 2 sense the damage and repair the cell, and the cell survive. But in case there is a BRCA1 or 2 damage, this whole purpose of repair will depend upon the PARP. At that point, if we add the PARP inhibitors, so no repair will happen, and cell increase, there may be increase in the cell death, which may be helpful in the chemotherapy and the radiation may work well. So PARP inhibitors and the recombinant repair. In DNA, single-strand damage can occur in cells at most of the time, which is sensed by the PARP, and this single-strand DNA damage is repaired. If we add PARP inhibitor at this point, the PARP will grab in the single-strand DNA. When this cell tries to divide, this single-strand DNA will convert it into the double-strand DNA damage. At this point, if normal homologous recombination repair is present, the repair will happen, the cell will survive. If there is no effective recombination repair, the cell death is imminent. This is the first phase 1 study of the olaparib, which was published in the NEJM in the year 2009. And in the early clinical activity, after studying the pharmacokinetics and pharmacodynamics of the olaparib, it was seen that 400 mg twice daily was the maximum tolerated dose. Even though this study was considered the patient with syndrome and the more cancer, we can clearly see the patients who are platinum sensitive, they show a better progression-free survival as compared to the patient who were refractory to the platinum. Also, the also the PARP inhibitors will work in wild type of BRCA patients also. It is because in a mutated patient, yes, PARP inhibitors will work, but in BRCA2 patient, where there is loss of heterogeneity is high, the patient will respond to the PARP inhibitor. But if there is low genomic index of loss of heterogeneity, PARP inhibitors will not work in those patients. Today, I am going to tell about the 2 studies in prostate treatment of the PARP inhibitors. First is the PROFOUND study. The criteria for this was the metastatic castration-resistant prostate cancer with disease progression on prior NHA, either with abiraterone or enzalutamide, Also, the second criteria is more than one of the any qualifying gene with a direct or indirect role in the homologous recombinant repair. These patients were stratified into cohort A and cohort B. In cohort A, BRCA1, BRCA2, and ATM treated patients were there, which were randomized in 2:1 randomization. And in cohort B, other type of mutation like BRD1, PRIP, CDK12, CHEK1, CHEK2, etc. These patients were either received the drug of the physician choice or olaparib 300 mg per daily. And the primary endpoint of this study was radiological progression-free survival in cohort A, and the other key secondary endpoints were radiological progression-free survival in cohort A and B, confirmed radiological objective response rate in cohort A, and time to pain progression in cohort A, and overall survival in the cohort A patients. Before going for the result, I'll tell you the most common acute in olaparib were the nausea, anemia, fatigue, and patient to first the arm has 2.52%, 3.52 months in the control arm. The overall response rate in cohort A was 33.3% as compared to the control arm, and the median interim overall survival in cohort A was 18.5 months as compared to 15.1 months in the control arm. The median overall survival in cohort A was 19.1 months in the patient who received the olaparib as compared to the 14.7% to the of the patient who were in the control arm. The one more thing which was very important, that 67% of the patient in the control arm were then crossover to olaparib arm within the 10 months of after randomization. So second study was a Triton study which present the result from the patient with metastatic castrate-resistant patient associated with BRCA 600 mg twice daily. In this study, 115 patients were enrolled who progressed after 1 to 2 lines of next generation androgen receptor directed therapy and one taxane-based chemotherapy for metastatic castration-resistant prostate cancer. The endpoint of the study was objective response rate and a locally prostate-specific antigen response rate. The confirmed overall response rate per independent radiological review and investigation assessment were 43.5 and 50% respectively. The confirmed PSA response rate was 54.8%. The most common grade 3 treatment related adverse event was the anemia. So this is the overall design of the study. 115 patients were enrolled who has received the next generation androgen receptor signal directed therapy. Those who progressed on that, then those who has the taxane-based chemotherapy, also those who have progressed and they were enrolled in the study. The confirmed objective response rate was the patient response out of 65, and in the control arm, it was 27 patient respond out of 62 patient. So author concluded that rucaparib encouraging anti-tumor activity in patients with metastatic castration-resistant prostate cancer and delirious alteration the BRCA1 or BRCA2 altered patient. Response to rucaparib were observed at a similar rate in patients with germline somatic BRCA1 or 2 alteration. Also, the confirmed radiological response and a PSA response were also observed in the patient in other with alteration in the other DRA genes, which include the ATM, CHEK12, CHEK2, PAL2, DRP1, FANCY, and RED 551V. So, thank you.
Thank you so much, sir, for such a wonderful talk. Now, moving ahead to our next talk, that is PARP inhibitors in ovarian cancer. For that, I would like to invite Dr. Suman Gupta. He is a senior consultant and head in the Department of Medical Oncology, Hematology, and BMT, and a director of Metro Cancer Institute, Faridabad. Over to you, sir.
Thank you, ma'am. I hope I'm audible.
Yes, sir.
And just give me a slide to run the slideshow.
Okay, sir.
Okay, so Dr. Nikhil has done my job very easy, and I could hide many slides because he has taken a very comprehensive discussion on the PARP inhibitors and how they work. So I'll be sticking to my role of PARP inhibitors in ovarian cancer. So PARPs have been something which have been a lot of which have generated a lot of interest to medical oncologists because ovarian cancer was one of the things where we did not have many options. So as Dr. Nikhil has rightly showed how the PARP inhibitors work and what is the mechanism of double strands and how the cell survival is stopped by the PARP inhibitors, I'll just come to a very simple slide. So basically, we have the BRCA mutations, which is very common in hereditary breast ovarian cancers. If we see this, whenever you have a mutation, the PARP mediated repairs the DNA breaks, and this causes the cell to live on, and the cancer cell just keeps on multiplies. So once you block the PARP with a PARP inhibitor, so you basically stop this and leads to a cancer cell death. So that is how fundamentally these PARP inhibitors work. But in ovary, once we understood that PARP inhibitors or the BRCA was a very important subgroup where we had to understand that these drugs work, we also came to understand with time that there is not only BRCA, there is HRR and HRD. So these are all the groups of unstable genes which are a key therapeutic target for these inhibitors. And if we see the a bulk of this in the hormone in the in the ovarian cancer, around 45 to 50% patients in long term we can find who will be HRD deficient or homologous recombinant deficient or HRD positive. So how do they work? This is a very simple thing. If you have HR and a base excision repair, you have to have the blockage of both these, and this is done with HR deficiency and PARP inhibition. So once you have the complete HRD with a PARP inhibition, you do not have any skipping from either the homologous recombination pathway or the BER pathway, which is for the single stranded DNA. So basically, you get a complete chances of cell death with these drugs. If we talk about PARP inhibitors, we have now, we started with olaparib, we had rucaparib. So basically, if we see 2014 was the time when the solo trial established olaparib, then came ruca, then came nira. And the next in block is veliparib, which is still awaiting its US FDA approval. So these are some of the key trials which are there in first line and second line ovarian cancer. So for olaparib, we had the solo 1 and the solo 2. For rucaparib, we had the Athena and the Ariel trials, which were very, very interesting trials because they also spoke of something new, which was heterozygosity in the BRCA genes, that is BRCA low and BRCA high. Then the niraparib trials, Prima and the Nova, and then the most interesting of all trials of the HRD positive subgroup, which is the Paola 1 trial. So I'll just try to skip through, just try to touch upon all these and see what we can understand in this particular subgroup. So phase 1, olaparib, we have seen, Dr. Nikhil has clearly shown that we started with a dose of 200 BD, from which we came down to 300. So coming to the landscape in ovarian cancer, we all know how ovarian cancer behaves. So you get diagnosed, you give chemotherapy, some kind of maintenance which has been discussed, and in most of your patient, you will have progression where you'll go to a second line, third line, fourth line chemotherapy till supportive care, or finally we lose the patient. So for anyone who has been treating ovarian cancer, we always think how we can increase this or how we can stop the transition to a second line chemo, that is relapse of the patient. So Linsparza or olaparib was the first drug which was approved in December 19, 2014. This was the study which was called as the Solo 1 study. Basically, it took all high-risk serous or endometrioid ovarian or fallopian tube tumors which were germline or somatic BRCA positive, mutant ECOG patient with 0 and 1 were taken. They underwent cytoreductive surgery, and then they were in a very good PR or a CR post the platinum-based doublet, which is the standard of care. They were randomized 2:1 into olaparib versus placebo, and this study was basically both PFS, OS, and PFS2 was taken in this study. So if we take the SOLO-1 primary endpoints, if we see the PFS, which was there, we clearly saw that at 3 years, there was a wide separation between the olaparib versus non-olaparib group. So coming to the conclusions, what we understood from SOLO-1, maintenance olaparib led to a substantial improvement in the PFS in the patients with newly diagnosed advanced ovarian cancer with the BRCA mutation. The graphs had leveled at 2 years, so we came to understanding that 2 years of adjuvant olaparib was the norm. Olaparib was generally well tolerated with a safety profile consistent with that in the which it also showed in the relapse setting, and that maintenance olaparib could be the new standard of care. So this is what we understood in 2014 with SOLO-1. Then, for continuing on the same, we had another landmark trial, which was the Paola-1 phase 3 trial, which was the final OS results of maintenance olaparib plus bevacizumab. So we all know that bevacizumab has been used as a maintenance agent in high-risk ovarian cancers, initially treated with a doublet plus minus bevacizumab. So this was the subgroup where this drug was added. So, but it was in this trial, basically they examined the efficacy and safety of maintenance Ola plus Bev versus placebo ovarian cancer who had received first-line SOC, including a Bev for at least 3 cycles. The current final analysis sought to assess any OS advantage at 5 years. So this is the trial schema, which is again quite similar to what we have seen. And if we see both the arms, the olaparib plus Bev plus placebo plus Bev was a very well balanced study. If we see the intention of the treat patients, if we see all the patients, we did not have any major divergence in the graphs. The 5-year OS was 47 versus 41%. When we came to subgroup understanding, that is the HRD positive, we could see a difference. So the 5-year OS was 65 versus 48%. So it was clearly shown that in this particular subgroup, there was a great benefit of 2 years of adjuvant drug. So this is again the PFS in the HRD positive subgroup. If you can see a gray difference or the divergence between the two graphs. And if we see all this, the BRCA, the HRD positive and the HRD negative, we could see definitely in the HRD and the BRCA mutant, the doublet was a clear winner, then only Bev alone. So a clinically meaningful OS benefit observed in HRD positive patients. 5-year OS was 65 versus 48, and observed even with 50% patients in control arm receiving PARP inhibitors post-progression. So this was something interesting, which is again a food for thought for further studies. Investigators concluded that these data supported the addition of olaparib to bevacizumab for the HRD positive patients with newly diagnosed ovarian cancer as a maintenance strategy. Then the second drug, the niraparib. So the niraparib trials also clearly demonstrated that the HRD or the BRCA positive arm was slightly better than the any intention to treat arm. Then came the most interesting study, which was the ARIEL-3 study of rucaparib. So the patient eligibility was a high-risk serous or endometrioid epithelial OCs, primary peritoneal or fallopian, quite similar to the solo group, sensitive to penultimate platinums, responding to platinum. So this was in multiple lines, CA 125 in normal range. Basically, we understood in all the PARP inhibitors that as a treating doctor, we should have a very good partial response or a CR to initiate these drugs. In resistant cases, giving a PARP inhibitor will not give us any further benefit. The stratification again was very interesting. It was BRCA, BRCA2 positive, non-BRCA HRR gene positive, or none of the above. So in the BRCA mutation, the primary endpoint or the PFS, they calculated into three subgroups, whether the patient was germline or somatic BRCA positive, germline in the HRD group, whether the germline or somatic BRCA plus BRCA wild type or LOH high. So they had given a concept of LOH high where they divided the BRCA negative groups into LOH high and LOH low for the heterozygosity, and they found that these also mattered. So this is one of the background reasons where we go back to Solo and Paula, that there was some response to the PARP inhibitors in the negative population also. So basically, when we are doing BRCA, I think we need more finesse to find out what are the subtypes of BRCA which will give us the right indication for a PARP inhibitor. So this is the schema as we discussed, and this is what we learned in the rucaparib Ariel 3 trial. In both the BRCA mutant and the HRD positive, we had a significant HR of 0.23 and 0.32. In the intention of treat, the HR ratio was again very significant. So in comparison to the other drugs which had been used, rucaparib tried to show us that it was working in all comers despite the HRD and BRCA, and it was something unlike the Solo trial. So basically post this, we had the biggest FDA approval of rucaparib for maintenance and treatment of recurrent ovarian fallopian tube or primary peritoneal cancers. Thank you. I'll be open to any questions. So basically what we can summarize is that in these settings, in ovarian cancer per se, in the BRCA, HRD, HRR arm, we have a great armamentarium with these 3 or 4 drugs. And I think the maintenance in patients who have achieved a complete response or a very good partial response, in PARP inhibitors is the way forward. Thank you.
Thank you so much, sir, for such an informative talk. Now, moving forward to a very interesting panel discussion, I would like to invite our moderator, Dr. G. Vamshi Krishna Reddy. He is a director and a senior consultant in the Department of Medical Oncology, Yashoda Hospital, Hyderabad. And our panelist, Dr. Rajiv Agrawal. He is a senior director and a consultant in the Department of Surgical Oncology at Medanta, the Med City, Gurugram. Dr. A.F.M. Kamaluddin. He is associate professor and consultant in the Department of Radiation Oncology, National Institute of ENT, Bangladesh. Dr. Sudeep Sreshtha. He is a founder and executive chairman in the Department of Medical Oncology at Nepal Cancer Hospital and Research Center. Dr. Ankur Varshney, he is a senior consultant in the Department of Medical Oncology, Medanta, the Med City, Gurugram. And Dr. Dheeraj Gautam, he is a director and HOD in the Department of Histopathology, Medanta, the Med City, Gurugram. Dr. Nikhil Ved, he is an associate consultant in the Department of Radiation Oncology, Artemis Hospital, Delhi. Dr. Ankur Mudgal, he is an associate consultant in the Department of Medical Oncology and Hematology, Medanta, the Med City, Gurugram. Over to you, sir.
Yeah. Good evening, everyone. Greetings from Hyderabad. So thank Dr. Ashok Vaid sir for providing me an opportunity to share about the PARP inhibitors in 2024. So I think the introduction for the panel was already done, and I would like to take a overview of how we treat with PARP inhibitors in various cancers. So I have tried to divide my talk into 4 sessions. So I'll try to complete in probably 10 minutes with each talk. So I'll try to ask a couple of questions to the esteemed panelists and give a summary of how we are dealing with it in 2024 April. So the first case I'll be starting is with the ovarian cancer, how we use PARP inhibitors. This is a 39-year-old premenopausal lady presented to me with abdomen. She presented with abdomen distension, and then on ultrasound abdomen, which she was evaluated by the gynecologist, there was ascites, momentum nodularity, and adnexal mass. CA-125 was elevated. She got a biopsy from the mental nodularity, and it was a high-grade serous carcinoma, and ascitic fluid was positive. So it was a stage 3C ovary cancer, and it was discussed as the MDT. We planned for NSCT, Paclitaxel, carbo, and Bev was given because she had gross ascites. We gave Bev at the cycle 1, and then by the end of third cycle, she had a great response. The CA-125 was 80, ascites disappeared. So there was almost a partial response, at least on the mental nodularity, but ascites was totally disappeared. So this patient was planned for interval cytoreduction, and then she was taken up for surgery. Optimal cytoreduction done. Post-op HP was showing significant residual disease. And with this report, we planned for 3 more cycles of Paclitaxel and carbo to be done. So this is what was done for this patient. So CA ovary, post-NSCT surgery done, 3 more adjuvant cycles were planned. So do we need to do anything else at this level? I think I'll ask Dr. Rajiv Agarwal, sir. So this patient...
Dr. Reddy, basically I treat only breast cancer nowadays. So I'll be participating more at the time of breast cancer discussion.
Okay, sir. Dr. Kamaluddin.
Sir, actually, he has not joined because of some emergency.
Dr. Sudeep Shrestha.
He is also in some function, so he was not able to join.
So Dr. Ankur Varshne.
Hi, good evening. I think we are missing an important test. We have not done the germline BRCA testing, nor we have assessed the HRD status.
Yeah. So I think what is the test would you like to do? So this patient was planned for testing. So what is it that you do as a protocol? Whether you go for, again, the debated thing, whether you go for the germline first or somatic or both at once, and do you refer for genetic counseling? Just a brief overview of how you test for the genetics thing for the ovary cancer.
We initially proceed with the germline first, and in case we got a positive result, we go with the genetic counseling, and then we proceed for the somatic mutation testing with a complete HRD plan.
Okay. Dr. Dheeraj, this patient went ahead with the HR testing germline. So you can see that this patient, we found that this patient had a BRCA1 positivity. BRCA1 is positive for this patient. So what would you like to do next for this patient? So CA ovary done with 3 cycles of Paclitaxel carbo and 1 Bev, now planned for adjuvant setting. So how would you like to sequence the case? So this is a ovary cancer, stage 3C post-NSCT with a BRCA1 mutated ovary cancer. So Dr. Dheeraj. So Dr. Ankur Mudgal.
Hello, hi, good evening, sir. So first of all, we will complete the 3 cycles, the remaining 3 cycles of the chemotherapy, and to add bevacizumab from the 5th and 6th cycle, so that will give some 6 weeks of gap after the surgery. And after completing the 6 cycles of the chemotherapy, we will continue with the Bev maintenance. With, if she is, as you are saying that she is BRCA positive, we'll add olaparib to it. So we'll continue olaparib for 2 years and bevacizumab for 15 months. This is our protocol which we follow in our institute.
Yeah, you want to go with the Paola one.
Right.
Dr. Varshne, so I think you want to complete with the Paclitaxel carbo and Bev, and then
yes, I think, but you have not mentioned bevacizumab in the neoadjuvant protocol initially.
No, it's mentioned. We have given at cycle 1.
Okay, then we will follow the Polar trial, and we will complete the adjuvant chemotherapy with inclusion of bevacizumab in the cycle 5 and 6, and then we will go with the combination of bevacizumab with olaparib.
Yeah. So I think this is what is the standard for this patient. So fortunately or unfortunately, this patient was germline BRCA positive. So we referred her for the genetic counseling, and it's a clear-cut case where the guidelines are very clear. So this patient received bevacizumab in the neoadjuvant setting. So we continued with Paclitaxel, carboplatin, bevacizumab in the adjuvant setting. And post 3 cycles, we plan to start her on olaparib and bevacizumab as per the protocol of the PALA 1. So do we have anything else to do for these patients? I think for the germline BRCA, I think as already shown in the earlier panel discussion by Dr. Suman Gupta. So we can go ahead with either the combination of olaparib and bevacizumab as for this patient, or we have evidence even for using the other PARP inhibitors also. So this about the PARP inhibitors in ovary cancer. So We have in the first line, we have great data for olaparib from the solo one with the BRCA mutated patients. And from the parallel one, as I think we have discussed, these high-risk patients who are BRCA mutated or HRD positive with, again, as was stressed, they need to have at least a partial response, or for the fortunate few, a complete response to first-line chemotherapy. Then only we should be pushing them for maintenance therapy with olaparib and bevacizumab. So olaparib is for 2 years if you are giving the adjuvant setting. Bevacizumab is for 15 months. So what are the other options available for these patients? So we also have niraparib, which was again stated in the PRIMA trial. This drug can be given irrespective of the BRCA status, but this is not available in India, so we'll not be discussing further. Rucaparib is another drug which can be considered as a single agent. So we don't have a combination arm for rucaparib. So this is the evidence which we have for PARP inhibitor in the ovary cancer. So just wanted to discuss about the PARP inhibitor in the recurrent setting. So first then it's very clear, anyone who has this BRCA mutated, we go with the olaparib, and for the high risk patients, we go with olaparib and combination. But in the recurrent setting, how are we going to treat? So so same patient, if we think that she had recurrence and it's a platinum sensitive and there is no prior exposure to PARP inhibitor, Dr. Varshne, like how would you like to treat this patient?
So it depends upon what's the disease status at the time of the relapse. Initially, what we usually see that these PARP, the patients who are BRCA mutated, they have especially platinum sensitive disease. So initially, I would like to control the disease with the use of chemotherapy, definitely a platinum-based chemotherapy, and then I will start the patient with the maintenance of either rucaparib or olaparib.
Would you like to check the BRCA status, or you want to go according to the BRCA status, or you want to start directly on rucaparib for all patients?
I think rucaparib is approved in the maintenance line without BRCA status. So academically, we don't need it. But in case if we definitely need to check BRCA status or HRD status, because definitely patient will be asking what is the prognosis with the use of this drug. So if we have the data regarding whether the patient is BRCA positive or HRD positive, we can explain him how much benefit patient will be getting with the use of this rucaparib drug.
Okay. I think I'll put the question in the next way, Dr. Dheeraj. So this patient is BRCA mutated. So which drug would you like to choose when there is a no prior exposure of BRCA status for this patient? There was no prior PARP inhibitor. This patient is BRCA mutated ovary cancer in the platinum sensitive setting. So received again rechallenge with the platinum partial response. So what drug you would like to choose if the patient were BRCA mutated? We don't have head-to-head trial comparisons. So it's de novo. Again, we have various trials, ANOVA, Ariel 3, and Solo 2, which have shown excellent HRs in the recurrent setting. So, Dr. Dheeraj, what would you like to choose in the recurrent setting for a platinum-sensitive disease? Dr. Ankur Mudgal?
Right, sir. So both olaparib and rucaparib both are actually right options. So we can choose one of them according to the patient's profile. So we can use one of them, olaparib either rucaparib. We usually prefer olaparib, so we can start with the olaparib.
Okay, so if the patient is HRD positive or BRCA mutated, you can choose any of the PARP inhibitors. Olaparib being probably more affordable. I think probably most of us have more learning curve with this drug now. So I think olaparib can be considered. So again, I think Dr. Nikhil Ved. So I think we have few patients in a sensitive setting where they are BRCA wild type. I think we have already discussed this. So we don't know the BRCA status. Do we need to really check? I think again, this was elaborated. We need not check, but I think for those patients who have this BRCA mutation positive, I think, or HRD positive, they respond very well. So what's your take on the BRCA wild type recurrent setting with a PARP inhibitor? Dr. Nikhil. Okay, so I think I'll pass on to the next question. So when there is a prior exposure to PARP inhibitor, like the outpatient who has received in the adjuvant setting of 2 years of olaparib, adjuvant olaparib with bevacizumab, if it's a platinum sensitive relapse, what would you consider in the rechallenge setting of a platinum sensitive disease? Dr. Varshne?
Again, it's a similar pattern question. After adjuvant olaparib, if a patient had a platinum sensitive relapse, definitely 2 years of adjuvant olaparib he had completed. So whatever the relapse will be, that will be platinum sensitive relapse only. We will go with the completion of chemotherapy first, And when disease is getting under control, then we need to put the patient on maintenance PARP inhibitors. If I have used olaparib in the adjuvant setting, then I would like to change it to rucaparib. So there is no head-to-head trial to show any benefit, but definitely I would like to prefer first the second PARP inhibitors as already one for failed.
Okay, so I think that was a point which I wanted to say. So when there is a relapse, platinum sensitive relapse, if the patient is responding to the chemotherapy, either a CR or a partial response, we do have some data to show that we can again re-challenge with the PARP inhibitor, probably the same or different. We don't have data to support any drug, but PARP inhibitor can be re-challenged in the platinum sensitive setting. So, Dr. Mudgal, so when do you consider PARP inhibitors in the platinum resistant setting? Would you still consider using platinum resistant in the present data, or would you go only with the chemotherapy?
So usually, sir, in platinum resistant is we usually prefer to go with the chemotherapy. So it's always better because if the patient is platinum resistant, then there is less likely that the PARP inhibitor will work.
Okay. So this was about the PARP inhibitors in ovary cancer. So in first line setting, we can use olaparib and combination as per the Paola in high risk ovary cancer in the adjuvant setting as maintenance, or olaparib and rucaparib in the adjuvant setting. In the recurrent setting, for BRCA mutated, we have any of the available options, olaparib or rucaparib. But for the wild type, we have more data for rucaparib. But for those with prior exposure to PARP inhibitor, this is going to be the scenario in the next couple of years because we are using this drug in the adjuvant setting now. We may have more data to re-challenge with the PARP inhibitor. Platinum resistant ovary cancer is one area where probably we don't see much benefit with the PARP inhibitors. So with this, we move to the next part of the topic, which is the PARP inhibitors in prostate cancer. So all of us know that PARP inhibitors do work in these patients with BRCA mutated or HR positive prostate cancer, but we need to know that few mutations are very much sensitive to PARP inhibitors like BRCA1 and 2. PAL-B2 is partially sensitive, and if we see someone with AT mutation, we need to understand this patient is not going to benefit. And one more thing which is very important in prostate cancer is when we see patients' disease going from the bone to visceral disease, we probably need to go for a repeat testing because these patients may have new mutations acquired in the HR thing. So this is what is important in a prostate cancer. So this is again one of my patients who was diagnosed in 2017 with the low Gleason's but high risk in view of the PSA being more than 20. He underwent bilateral orchiectomy and started on tablet bicalutamide, which probably the urologist did, and then stopped after the PSA was normal for 2 years. Then he was under follow-up with the urologist. His PSA slowly started rising after 6 years. Got a PET CT. Unfortunately, he had 2 liver lesions and multiple bone metastases. Still, the testosterone was in the castrate level. PSA was high. Biopsy from the liver lesion was suggestive of prostatic adenocarcinoma with IHC. Because of the high-risk disease, we have started him on docetaxel with prednisolone, abiraterone instead of darolutamide because of the financial issues. We started the triplet regimen. He completed 6 cycles of chemotherapy, had a great response, completely disappeared liver lesions. He was continued on abiraterone and prednisolone. Genetic testing was delayed till probably he completed chemotherapy. It was done. And this was the report of the genetic testing. So Dr. Varshne, so what do you think we'll be doing next? So this patient is a HRPC, started on dose triplet regimen, doing well on abiraterone. When would you like to sequence your next drugs?
So ideally, if I go with academic discussion, the patient should be tested for BRCA mutation and HRR pathways at the baseline when he was diagnosed with a metastatic disease. Then, but if the patient has not been tested of this mutation, so early as possible, whenever we found a relapse, we should test this patient with the HRR panel. And regarding the data of use of PARP inhibitors, so upfront we have the data of PROPEL and PROFOUND studies where abiraterone can be combined with PARP inhibitors and can be used in upfront settings also.
Yeah, I think so. We do have data. Dr. Mudgal, would you like to add anything? So PARP inhibitors in this setting. So would you like to combine right now, or you want to delay it for the further use? So that's what
Both ways we can do, sir. So we can combine it right up front also, and we can wait for the disease progression, and then we can also combine. Then we can start the PARP inhibitors if there is a disease progression. So both ways it is correct.
Okay, so as I think was said by Dr. Vaishnav, so we had good data from the PROFOUND where they have compared olaparib with the physician's choice. This was again a single agent therapy. So you can see that the PFS and OS widely separating between the BRCA mutated and the standard arms. And if we see the subgroup analysis, it's only to see who did better on olaparib. We can see that the BRCA2 and 1 mutations did really well. There were few mutations, I think they did not do that well with olaparib. And based on this, olaparib and most of the rucaparib are approved as monotherapy in prostate cancer based on the data which is available, mainly for those patients with BRCA mutated or HRR mutated metastatic castrate-resistant prostate cancer, not in the HSPC setting, who have progressed on at least prior enzalutamide or abiraterone for metastatic disease. And again, rucaparib was approved for those patients who have progressed on at least one hormonal therapy and a taxane. This is the European indication where they have considered using the olaparib for those patients who have progressed on at least prior hormonal therapy for a metastatic disease, and it should be continued until progression. Niraparib and talazoparib are not currently approved. So this was about the olaparib and rucaparib as a monotherapy, which are approved indications post hormonal therapy. Olaparib has great evidence. Triton 3 for rucaparib showed that with compared to docetaxel for those patients with BRCA2, this did really well. So for all patients with prostate cancer, we need to do the germline, tumor, and ctDNA testing to identify those patients with HRR deficiency, to choose those patients who will benefit from this PARP inhibitor monotherapy. Again, so as was said, combination therapy. Now, whom we should go for the combination, whom we should go for monotherapy. We have 3 trials of Propel, Magnitude, and Talapro, which are published, and all of them have shown benefit with the combination arm also. So olaparib was studied with abiraterone. We can see that for the HRR mutated patients, it did really well. The hazard ratio of 0.66 in a HRPC is great. So for those who are not HRR, we can see that HRR was only 0.89. Again, the magnitude also was compared with abiraterone and niraparib compared to placebo. Again, we can see this benefit was greater in those with the BRCA mutated compared to the HRR. Talazoparib was again tried with enzalutamide in the first line CRPC. So again, this showed favored subgroup analysis in few of the BRCA mutation and PALB2 compared to other mutations. So conclusions of all this combination arm was that the Magnitude and Propel trials showed improved PFS with those patients with HRR mutated with a combination of either abiraterone and enzalutamide with the PARP inhibitor in first line. But there was conflicting results in those patients who did not have this HRR mutation. So talazoparib we will not discuss because we don't have that available. But again, for academic sake, this improved PFS with or without the HRR mutated in the first line. So I think we'll be moving from probably monotherapy to the combination with PARP inhibitor and hormonal therapy in prostate cancer. So that's what the future looks like. So for this, I think we had regulatory approvals for olaparib in combination with abiraterone and visolone for those patients with BRCA mutated CRPC like our patient. So this patient, as was said by Dr. Varshni, that we can go with a combination of olaparib and abiraterone as maintenance for this patient. We also have combination of niraparib and abiraterone for those patients with this BRCA mutated CRPC. Again, talazoparib is also indicated, but it's not available. So I think we'll be discussing only about olaparib. So we have one drug, olaparib, which we can continue with combination of abiraterone in prostate cancer. So we'll be talking about the breast cancer PARP inhibitors. So I think Dr. Rajiv Agarwal sir. So when do you consider using this PARP inhibitors in breast cancer, both in the adjuvant and metastatic setting, and also in light of the hormone status and HER2 status? Dr. Rajiv Agarwal sir.
Yeah.
So a role of PARP inhibitors.
What was the question, sir?
What is the role of the
Am I audible?
Yeah. When do you consider using the PARP inhibitors in breast cancer? So I think we discussed about in other indications. So in breast cancer, we wanted your opinion.
No, I think it is high time that PARP inhibitors
Dr. Rajiv sir, your voice is not audible.
Hello.
Yeah, I think you are
Am I
audible.
audible?
Yeah, now you are audible, sir.
So during the
I think you have poor connection, sir. We are unable to hear you. We'll pass on to the next panelist, Dr. Dheeraj. If you are available, you can take on the question. I think sir is facing some network issues. So when do you consider using PARP inhibitors in breast cancer, both in the adjuvant and metastatic setting?
I am not a clinician, I'm a pathologist, Dr. Reddy. So,
sorry.
Yeah.
And then I think we should be asking about when do you consider testing for the BRCA in breast cancer? And what's the test you are doing in your center?
We are doing ISC as well as the fish.
Okay.
So, yeah,
so
both.
Fish and ISC is for ERP or HER2. So if you get a TNBC, when are you testing for the BRCA status? You are doing for the NGS as the germline, or you are doing the somatic testing? How are you considering?
Basically, for BRCA, we are doing germline as well as the somatic. It will depend upon the history of the patient, and we are doing by NGS with MLPA method.
Okay. Yeah. So would you like to share more on testing for other cancers as well, like the prostate and the ovary cancer? Like when you get samples for those
Breast,
patients?
usually we are doing for the breast cancer as well as the ovarian cancer and endometrial.
Okay.
These are the indication. Prostate, we have not received so many prescription for the prostate cancer for the BRCA. So,
okay.
And it will depend upon the history of the patient. If there's a family history, then we will go for the germline. If there's a single mutation or a isolated case, then we'll go for the somatic mutation.
Okay. Are you seeing a recent rise in the prescriptions asking for
Yes.
more testing from your doctor?
Yes.
Okay. So that was the intention to ask about this, because
yes.
I think now the widespread availability of the PARP inhibitors at an affordable rate. In the near future, we are going to see more and more patients being tested, mainly those with breast cancer, the ovary, pancreas, prostate, and probably many more cancers, where we'll be considering testing for both the germline and the somatic testing for the BRCA1, 2, PALB2, ATM, and various HRR genes. So I think probably we may have extended usage of PARP inhibitors in various cancers. So I think I'll go to the clinician again, Dr. Varshni. So PARP inhibitors in breast cancer, when would you like to use?
Okay, so I think what I would like to add to what Dr. Dheeraj has already told, what are the indication to send? Definitely any TNBC, any young patient with a concomitant past history of any breast cancer, ovarian cancer, or the family history of any breast cancer, ovarian, prostate, or pancreatic cancer. So all these patients we would like to subject to BRCA testing. So among these indications, if I got a TNBC patient who is a BRCA1 positive or BRCA1 or BRCA2 positive, and we will start with the NSCT first, and this patient has a residual disease, we go with the BRCA maintenance in this adjuvant setting for 1 year. And in metastatic, definitely post multiple lines chemotherapy, we can use in BRCA positive patient, we can use olaparib as a treatment indication.
Yeah, well said, Varshni. So I think we need to test for both the germline and somatic mutations in breast cancer. All those patients who are identified to be having high risk, they should be given adjuvant olaparib for 1 year. So in breast cancer, it's only for 1 year. That's what we need to remember. And in the metastatic setting, post at least 2 lines of chemotherapy, if the patient has any of the somatic or germline mutations, we may consider using the PARP inhibitors. So coming to the last part of the talk for the pancreatic cancer. So all of us know that in pancreatic cancer also we have this BRCA1 and 2 and the PAL mutation in 5 to 10% of the patients. And how is the use of this PARP inhibitors in prostate cancer, pancreatic cancer, Dr. Mudgal?
So, sir, after completion of chemotherapy, if the patient is BRCA1 positive or BRCA2 positive, then we can use it as a maintenance therapy with olaparib. So we usually do it, but the chances of probability of BRCA positivity in a pancreatic cancer is very low. Actually, it's around 2 to 3% only, I think. So that's why we are seeing very less number of cases with pancreas that are started on olaparib maintenance. So this is the treatment strategy which we follow here.
Okay, Dr. Dheeraj. So have you seen the BRCA testing in the same proportion as what is reported in literature, probably 5 to 10% is quite a high number, which we are not seeing in our practice.
No, it is low in our setup. Probably West, it is high.
Yeah.
So I don't have a data, but yeah.
Yeah, please tell. Dr. Dheeraj, you can continue.
Pardon?
Please, you can continue. So for the pancreatic
Yeah.
cancer, your population, if you're seeing the incidence is still less for the BRCA mutation.
I didn't get you, sorry.
The testing is less or the detection rate is less in pancreatic cancer?
Pancreatic testing is less. What we received, the prescription are less, but in last 6 months and 1 year, probably we are getting some few tests. And believe me, we have a very good center for BPLs and pancreatic cancer. So, but probably it's not going. It's the surgeon who is not prescribing. If it is going to the oncologist, probably they are prescribing it.
Yeah, I think so. That's the irony. So I
Yeah.
think all of us need to probably send more and more specimens for testing. I think the issue
Yes.
most of the times in pancreatic cancer is that most of them in the metastatic setting, we have difficulty in accessing enough tissue for the NGS testing for the HRR panel. So I think because of the paucity of tissue, I think we need to concentrate more on probably the liquid biopsies and the ctDNAs for testing in pancreatic cancer. So again, in pancreatic cancer, we have good evidence from the POLO trial where they have considered using olaparib for those patients with metastatic prostate cancer. This is not in the adjuvant setting. This is in the metastatic setting for those with a germline BRCA mutation. So what's the beauty in pancreatic cancer is that if you can see that post chemotherapy, if they have a good response, if you are giving olaparib, this is giving a median OS of around 7.5 months, which probably pushes them beyond a year, and again you can re-challenge with chemotherapy. So that does not happen if you are stopping chemotherapy. So this is a great thing, but unless you test, unless we try to see more patients getting diagnosed with this BRCA mutations, we may not see this number. So the PARP inhibitors in pancreatic cancer, what we need to see that most of the patients should be offered germline testing and also the somatic testing to see for two HRD mutations. One is a core, second is a non-core HRD. Core HRD is the BRCA1 and 2 and the PALB2. Others are non-core HRD. So for those patients with this HRD mutation, we need to offer maintenance therapy with olaparib. Post chemotherapy, after they have a good response, we need to consider maintenance olaparib. So that's all about the olaparib and the PARP inhibitors. So we have tried to elucidate the usage of these PARP inhibitors in various cancers. And as I think Dr. Ashok Vaid sir said, the indications are expanding every day. So it started with the monotherapy. We are seeing evidence for combination therapy, and probably we may see the combination immunotherapy also. We have trials coming with robust data. I think probably that should be the standard of care in the next couple of years. So from ovary cancer, where we have the usage mostly in those patients with the BRCA mutated and the HR mutated, HR deficiency patients, we also have the same indications probably in pancreatic cancer, the breast cancer, and also the prostate cancer. So as of now, the availability, we have olaparib and rucaparib, which are widely available. So drugs available, and we have the good number of tests which are available by various companion diagnostics. So you need to just push for the test and see the appropriate patient being started on these drugs. So thanks everyone. Thanks for being a great panel. Thanks Dr. Varshney, Dr. Gautam, and the team BDR. Thank you.
Thank you so much, sir, for such an informative and interesting panel. Now, for the vote of thanks, I would like to invite Dr. Suman Gupta, sir. Over to you, sir.
Thank you, Anshika. So, Dr. Reddy, I must congratulate you on such a nice and lucid panel. It was very, very knowledgeable, and you had such a good panelist to assist you. And the other speaker, Dr. Ved, it was lovely listening to you in the prostate cancer. So as you rightly said, this is a drug this is the group of drug which is going to make a difference. The only thing which is going to limit our use right now is the cost of testing. So once we have a cheaper tests available, I think we'll be using it in more and more cancers, and we'll see beautiful results everywhere. So I must thank everyone for joining us, all the faculty members, the BDR team, and above all the MICE team for having this beautiful session. Thank you, Dr. Vaid, for giving me this opportunity, and the Indian Oncology Foundation also for giving me this opportunity. Thank you, and have a very good night.